Really my pleasure to invite our experienced cornea consultant, Dr. Osama Gelidi. He's ophthalmic consultant at Moorfield Eye Hospital in Dubai.
Good morning, everyone, and thank you for the scientific committee for the invitation. So basically, I'm talking about when and how to use intercorneal ring in the management of keratoconus. No financial disclosure for this talk. As you know, the method to improve the vision for keratoconus is glasses, contact lens, and if that's not good, then intercorneal ring an option, topo-guided BTK, or the last resort is cornea graft. Basically, the intercorneal ring is very useful tool for visual rehabilitation of keratoconus if the patient cannot see clear with the glasses and he cannot tolerate contact lens. Usually for grade 1 and 3, because once you have the cornea scar for grade 4, the vision potential is not good. So our aim for the patient is very important too when we consider intercorneal ring. Our aim to the patient not to get rid of the glasses. So we want to improve his vision so he can see better with the glasses. And sometimes people can be better with the contact lens used after. Regarding intercorneal ring, there's too many different size, thickness, and diameter available. Usually we start, long time we start with Intax. Now it's Intax CK, but more people using Ferrari ring and Kira ring. Mayo ring is a different design, which is complete ring. The disadvantage really, you have to make large opening and dissection all the way. So I don't use it myself. And then new trends now we think about, because instead of using a plastic, we could use a human tissue, what you call CARES, instead of the plastic one. Still looking for the result of this new technology. There's also different design, like progressive design, thicker one side, thinner one side, or thick in the center, thin on the periphery. So there's different design. It can be used to modulate. The insertion of the surgery itself is really simple. Once initially we use a mechanical, manually, diamond is more tricky, but with femtosecond laser use, it's become the procedure very simple. It's very consistent. It's very good centration. We aim it for 70 to 80% of thickness. And really is less trauma and risk of perforation. So the procedure is very simple. It takes seconds to create the tunnels. The principle of the cornea ring, when you implant a segment, so basically you elevate the periphery, so you're flattening the center. And at the same time, also you change the force for the progressive keratoconus, but also you could play with the symmetry. So it depends on the thickness of the rings itself. So the thicker the rings, they have more affected. And also the more smaller diameter, they have more effect in the reducing the myopia. The shorter the segment, it have more effect in the stigmatism and the symmetry. If you have two different symmetry rings, that can improve the symmetry of the cornea itself. So it's all studies show that by using the rings, reducing the myopia, symmetry of, and improve the vision, improve the anisotropia. Also, there's improvement of contact lens intolerance. Some people cannot tolerate contact lens. After you put the rings, some of the patients become tolerant to contact lens. So, and the aim is just to improve the quality of vision. They always add, so it's not reducing the strength, but if you're concerned about the progressive keratoconus, the ring itself is not enough. So you need to consider cornea cross-linking. It's well documented. We had a long study, one of them 10 years, 9 years, and one 5 years, and it's really very safe, predictable procedure. The advantage is very safe, effective, it's reversible. If there's a problem, you could remove the rings, like this one is the top of the ring, you could see the track of the ring, but although there's no rings, if it's overcorrected or there's a problem with the rings, as we mentioned, improve the tolerance of contact lens. The complication rate is very low, especially with the femtosecond laser, so, and had very high satisfactory patient recovery fast, so the patient is very happy, majority of them. Although there's disadvantage of the ring, as the most really tricky one is the predictability of the rings. So when you put the rings, always tell the patient that it's not as predictable, although with experience you can know this patient is very good and we have better vision than other. Infection, extrusion, and glare. And very important to measure the pupil size. That's because if someone had larger pupils, if you put the rings smaller, you will have more glares. It could combine with cornea cross-linking in the same session or after. I usually personally put the ring first to understand that patient improve with the rings, then I do cross-linking. Some people using the same time, but once you do cross-linking with the rings, you don't know is the rings did good vision or not, because the cross-link will make the vision blurry, so you cannot have that perception. And also, you could do, if it's more regular cornea, and instead if you do BTK, it's better to do the ring first. So the ring is to improve that to severe irregularity and leave the BTK for refining. So that's and cross-link. So these three different procedures could be interacted to get better patient satisfaction, better vision. What expected? George Aleo did a review for 100 study, and really all the studies show spherical equivalent improve it in mean of 1.5 to 3.5, although some of the, if you select different cases, you could be much better than that. Also the stigmatism reduced and reducing the K reading. Nomogram is still tricky, so usually it's looking to, it will improve more and more with time. Usually we look into the topography, is it symmetry or not symmetry, because that will help you to decide you want to put one ring or two rings or asymmetric ring, refraction, and you look to the coma, and usually most of us will do the incision in a steep area, and you could refine tuning and table or replacing the rings after the surgery. This is some of my cases, so basically, this patient, for example, is like for diopter astigmatism. After ring is dropped to 1 diopter, and this the best corrected visual acuity with the glass improved dramatically. So I did one ring for this patient. This is after that. I don't do the simultaneous also. I do one eye and check it. I don't do the two rings in both eyes at the same time. So it's always be. It's at least you can learn from the first result. You can adjust the other one if you want. And after the patient is happy, I put the rings. After a month, I do cross-linking. And this patient did cross-linking, and we just monitored everything is stable after cross-linking. This is another patient which is very high stigmatism, is 9 diopter astigmatism. And if you look to, so this is the before surgery, this is after surgery, and this is how much flattening effect in the patient. And this patient had, we inserted 2 asymmetric rings, so thicker in the bottom and superior, thinner in the superior, which is the most common for keratoconus, this shape. And this is his other eye, and the big improvement in the stigmatism and the coma of this patient, and more important, really, the patient can see with the glasses. Conclusion, intracorneal is a very effective way to treat, to improve the vision in keratoconus patient, grade 1 and 3. It improves the best corrective visual acuity, and also could make the patient tolerated to contact lens. As we know, the vision with contact lens is the best vision ever patient will see with the contact lens. I always encourage everyone to try to push your patient to try contact lens first before going to any other modality. It's have long-standing safety and very low complication rate. Important to select the ring, thickness, diameter, and always really is very important nowadays. Better stop using manual way. It's femtosecond is make your life easy, the surgical more producible, and less risk of problems, because that whatever you experience with the tunnel, surgical, always the tunnel cannot be predicted. The depth, it may be deeper one side, thinner one side, so that will allow the rings to migrate. Before I forgot, always advise patient not stop eye rubbing. Not for the keratoconus only, progress, but when you have the ring firm, sold, and you patient rubbing, that also can make it melting in the ring itself, and that's what the problem with extrusion. It can be reversible, it's add. So the good things with the ring, we don't weaken the cornea. We add strength to the cornea. If there's any issue with the progressive keratoconus, you need to consider cornea cross-linking, and it's very good way to improve the bigger irregularity, and you could use the Tobogade BTK to refine it. And thank you very much.
Thank you, Dr. Gelidi.